I'm going to actually present the next two cases sequentially because this pertains more to our next speaker's topic. And they're two very different cases. And after the presentation, I'm going to bring up Alan Ho, Dr. Ho, and have him talk a little bit about molecular markers on thyroid pathology specimens and how he might potentially use that in either of these case settings. So the first one is a 38-year-old female who is status post-total thyroidectomy, central neck dissection for papillary thyroid carcinoma. Her pathology initially showed 1.2 centimeter nodule with extrathyroid extension, and tumor was present at the cauterized margin. There was angiolymphatic invasion, and central neck nodes were positive. She did not have any history of prior radiation. She did actually get treatment for breast malignancy. Now, she, she did not have breast cancer. I apologize. So she had no cancer of history, no radiation. The mother had the thyroid cancer and breast cancer, so I apologize, and grandmother had breast cancer. She then got 148 millicuries, and the post-uptake scan showed uptake in the neck only, and the pre-treatment thyroid globulin was 57. 3-month post-ablation suppressed thyroid globulin was undetectable, and then the 1-year post-treatment thyroid globulin rose to 1.88. So at this point, the patient was actually sent to our medical oncologist, who you may know, Alan, at our institution, who does thyroid cancer chemotherapy. Anyway, so the patient got ultrasound at our institution, and you can see there are several sub-centimeter lymph nodes in the central neck, as well as one in the level 4 lateral neck. And that was FNA'd and was positive. So after much discussion about what to do with this patient, this Delphian node, this 6 by 5 millimeter prominent Delphian node that was FNA'd positive, was the one that she decided, let's just take this out and let's see what happens to the thyroid globulin. I'm not going to sit here and debate about whether that was the right decision or the wrong decision. That's not the point of this panel. So after that, her thyroid globulin level didn't budge, okay? So then she's back again, and again, the repeat ultrasound shows similar lymph nodes in the central neck that did not particularly look suspicious, but there's this level 4 node now that's gotten a little bit larger, and now the ultrasonographer and I also felt that it looks somewhat suspicious. So she basically insisted on an FNA. And the FNA of that level 4 node was positive. So now we got a patient with these central neck nodes that are indeterminate at this point in time. They're all small. Now you've got a level 4 node that's positive. And she's asking me, what do we do? Do we go in and operate? Do we just sit on these? These are small tumors. What about my history? My family history of breast cancer and all this. Does this all, play a role? And her specific question to me was, is there any role in looking at tumor markers to help me determine what to do next? So that's the first question on this case. So this sounds like a very indolent kind of papillary carcinoma with just some lymph node disease that some of us may consider to be minimal tumor burden disease. But she does have a very strong family history of thyroid and breast cancer. The other spectrum is a second case, which is a 64-year-old male who actually presented to an outside institution with seizure, and on the workup they found a 2-centimeter brain lesion, so they went in and surgically removed it, and that was found to be metastatic papillary thyroid carcinoma. And then he arrived at our doorstep. Thyroid ultrasound showed a 2-centimeter left-sided thyroid nodule, And there was a second one that was 1 centimeter. He was then found to have multiple lung lesions and mediastinal lymph nodes, as well as bone metastasis. So after much discussion at the tumor board, it was decided that he would go ahead and undergo the total thyroidectomy and the central neck dissection. And then the next question was what to do after that. Do we treat this patient with radioactive iodine at all? Do we proceed right to radiation therapy? And clearly chemotherapy is going to play a role. And the major question is, does molecular profiling help in selection of the treatment of this patient? So I wanted to bring these two cases up, the two totally different spectrums, and I wanted to bring Dr. Alan Ho up to discuss the role of molecular profiling in subsequent management of these thyroid cancers that have two different spectrums of presentation.